Let us see diagnosis of asthma. Most important criteria for diagnosis of asthma will be the spirometry criteria. Spirometry criteria. What are the spirometry criteria? Asthma will show obstructive pattern. It is going to show you obstructive pattern. Now even COPD is obstructive. How is asthma different? There is bronchodilator reversibility. When do you call it as bronchodilator reversibility? There is increase in FEV1 more than 12% or in terms of volume 200 ml after SABA inhalation. What is SABA? Short acting beta 2 agonist. What is its function? Bronchodilation. What is the frequently given SABA? It is salbutamol. How it is done? If at all a patient's FEV1 initially was 65%, now you have given a short acting beta 2 agonist and after 15 minutes you repeated the test. Now his FEV1 has become 80%. It means there is improvement more than 12% after short acting beta 2 agonist inhalation. Will this much amount of improvement happen in COPD? No. Second important test is peak expiratory flow rate variability more than 10% in a day. When will an asthmatic have more symptoms? Early morning. Early morning, because of cold weather there will be bronchospasm. Now if you ask him to blow the PEFR, he cannot blow properly. In the morning PEFR will be less. By afternoon it can increase. Again in the night, because of cold weather it will decrease. If in a day there is change in PEFR with respect to various parts of the day, your diagnosis should be suggesting asthma. And third important thing is bronchoprovocation testing. Bronchoprovocation testing, also called as Methcolin challenge test. Also called as Methcolin challenge test. You must be knowing this Methcolin is a bronchoconstrictor substance. On inhaling Methcolin, there will be decrease in FEV1 more than 20% after Methcolin inhalation. Now you should get a valid doubt, students. Even a normal person, when he inhales Methcolin, there will be bronchoconstriction, decrease in FEV1. Now how will you tell that this decline is only because of asthma? See here, students. If a normal individual requires 1 mg of Methcolin for bronchospasm, in asthmatic 0.1 mg is sufficient. Even with a very low dose, asthmatic's airway will become closed. What is the reason behind that? Because asthmatic airways are hyper-responsive. This will be the test for airway hyper-responsiveness. This will be the test for airway hyper-responsiveness. Coming back to the definition, we have discussed asthma is a disease with symptoms. Why it is happening? Because of bronchospasm. What is the type of bronchospasm? Reversible, variable. And why it is happening? Airway hyper-responsiveness to variety of stimuli. Airway hyper-responsiveness to variety of stimuli. But for clinical practice, most important will be the first criteria: obstructive pattern, bronchodilator, reversibility. Unfortunately, few patients with asthma can worsen and reach the emergency department. It is called as acute severe exacerbation of asthma. The old name is status asthmaticus. Now you should only call it as acute severe exacerbation of asthma. Let us see the clinical features. The clinical features: patient speaks in single words. Clinical features: patient speaks in single words. Patient speaks in single words. He will be having shortness of breath at rest. Shortness of breath at rest. His respiratory rate will be more than 30 per minute. His heart rate will be more than 120 per minute. If you look that patient, he will be using his accessory muscles for respiration. There will be accessory muscle use, acute severe asthma. And this patient, if you put your stent, there will be bilateral wheeze. If you put your stent, there can be bilateral wheeze. And next, there is a phenomena called as pulsus paradoxus. There is a phenomena called as pulsus paradoxus in acute severe asthma. Coming to the functional criteria. If you look at the functional criteria, this patient's PEFR, will be less than 50% of predicted value. Predicted value means value normal for that given age. His SpO2 can be less than 90%. His PaO2 can be less than 60 mmHg. These are the features of a patient with acute severe asthma. Now let us see one by one. What is meant by patient speaks in single words? Whenever you ask a normal person his name, he will answer like this: my name is so and so, I come from this place. He will speak continuously. Whereas in acute severe asthma, because of respiratory discomfort, if you ask the patient's name, he will reply like this: my, he'll take a breath, name, he'll take a breath, is, he'll take a breath. Because of respiratory discomfort, because of respiratory distress, he cannot speak continuously. He will be speaking in single words. He will be having shortness of breath even at rest. His respiratory rate will be high. Heart rate will be more. He will be using his accessory muscles for respiration. If you put your stent, there will be bilateral wheeze. And there is a phenomena called as pulsus paradoxus. First of all, students, you should know this pulsus paradoxus, is it relationship with pulse or relationship with blood pressure? It is actually relationship with blood pressure. Now in respiration, there are two phases. One is inspiration, other is expiration. Now tell me, during which phase systolic blood pressure is slightly less? Generally during inspiration, the systolic blood pressure is slightly less. Now what is the reason behind this? Whenever I take inspiration, there will be more negative intrapleural pressure, which will facilitate more blood reaching the right heart. From the right heart, blood goes into the pulmonary circulation. During inspiration, what else happens? Your lung expands. Whenever your lung expands, the caliber of pulmonary circulation also increases. Whenever the caliber of pulmonary circulation increases, transiently more blood will stay in the pulmonary circulation. Because more blood is staying in the pulmonary circulation, less will go into the left heart. Because less is going into the left heart, the cardiac output slightly decreases. Because of that, during inspiration, there will be a slight decrease in SBP, usually less than 10 mmHg. Now, because of some disease, if there is exaggerated fall in SBP during inspiration, this exaggerated fall in SBP during inspiration, it is called as pulsus paradoxus. Let us see why it happens in acute severe asthma. In acute severe asthma, there will be bronchospasm. Now to overcome this bronchospasm, should the patient take more respiratory effort or more deep inspiration or less deep inspiration? To overcome this bronchospasm, now patient will take a more forceful inspiration. So whenever he takes a more forcible inspiration, the intrapleural pressure will become more negative. Whenever the intrapleural pressure becomes more negative, more blood will reach into the right heart. If more blood reaches into the right heart, it will go into the pulmonary circulation. And whenever patient takes a deep forceful inspiration, when he was taking normal inspiration itself, his lungs were expanding. Now the lungs will expand more. Once the lungs are expanding more, the caliber of pulmonary circulation will increase more. So more blood will now be staying in the pulmonary circulation. If more is staying here, less will go into the left heart. If less goes into left heart, there will be exaggerated fall in SBP. This exaggerated fall in SBP, this exaggerated fall in SBP during inspiration due to rapid changes in lung volumes and intrapleural pressure. Due to rapid changes in lung volume and intrapleural pressure is responsible for pulsus paradoxus. This exaggerated fall in SBP during inspiration due to rapid changes in lung volumes and intrapleural pressure is responsible for pulsus paradoxus. Now there was a patient with acute severe asthma. If you don't treat him properly, if you neglect him in emergency department, what might happen? If patient is not treated properly, if not treated properly, the disease can progress, resulting in life-threatening signs, What are the life-threatening signs that you should know? Because of continuous hypoxemia, patient can go into altered sensorium. Because of continuous hypoxemia, patient can go into altered sensorium. Now, previously there was some space within the bronchus for air to go in, come out and create wheeze. Now as disease progresses, there will be near total bronchial obstruction. When the bronchi are nearly obstructed completely, what will happen? Nothing will go in, nothing will come out, because air is not flowing properly. There will be no breath sounds. Because air is not flowing, there will be no breath sounds. This phenomena is called as silent chest. Then a normal person's respiratory rate is about 12 to 15 per minute, but this fellow is taking at 30 per minute. Now suppose if your normal capacity is to run for 2 kilometers, if I make you to run for 4 kilometers, what will happen? Your muscles will undergo fatigue. Now you cannot even walk properly. In the same way, because of more and more respiration, at some point of time patient will develop respiratory muscle fatigue that will result in decreased respiratory effort. Now whenever there is decreased respiratory effort, inspiration will not be proper. So the amount of oxygen coming into your body will be less. Expiration will also be not proper. The carbon dioxide going out from your body will be less, that results in increased CO2. There will be further decline in oxygen in the body, decreased SpO2, decreased PaO2. Gradually CO2 increases. There will be increasing CO2. If you find any one of this feature, this is considered as a life-threatening feature, because if you don't intervene, if you don't intubate, patient is not going to survive. If asthma is not treated properly, it can develop life-threatening signs: altered sensorium, silent chest, decreasing respiratory effort. Because respiration is not happening, oxygen will not come into the body, carbon dioxide will not go out. So oxygen further decreases, CO2 increase in the body. Let us see how to treat this acute severe asthma. Write down treatment. Whenever you identify a patient with asthma exacerbation, start oxygen in the emergency department and give nebulization. Nebulization with bronchodilator such as short acting beta 2 agonist. Along with that, you can add SAMA. What is meant by SAMA? Short acting muscarinic antagonist. You must be knowing bronchodilators are of two types. One is short acting beta 2 agonist, other is anticholinergic. Anticholinergic is also called as short acting muscarinic antagonist. Anticholinergic, frequently given anticholinergic is ipratropium. Frequently given anticholinergic is ipratropium. Along with this, you can also give ICS. ICS means inhaled corticosteroids. ICS is inhaled corticosteroids. Then this patient requires IV steroid. The reason is to decrease inflammatory response. IV steroid to decrease inflammatory response. When patient is not improving with above medication, a trial of intravenous magnesium sulfate helpful. A trial of intravenous magnesium sulfate is helpful. What is the role of IV theophylline such as aminophylline? According to new guidelines, now not recommended. Previously, we were giving IV theophylline, but IV theophylline was associated with cardiac toxicity. Now we are not recommending IV theophylline. So what will be the treatment? Oxygen nebulization, steroid. If patient is not improving above medication, with above medication, a trial of magnesium sulfate. This magnesium sulfate has a remote bronchodilator activity. A remote bronchodilator activity, it can be helpful here. According to new guidelines, IV theophylline now not recommended. If at all patient becomes bad and if there is life threatening asthma in life threatening form, by the time patient reaches you, he will be in altered sensorium. I should directly go for invasive mechanical ventilation done. And what is the strategy here? Strategy is high inspiratory flow and prolonged expiratory time. High inspiratory flow and prolonged expiratory time. Now what is the benefit of this strategy? Now when this patient reaches me in life threatening form, his bronchus will be completely closed like this. Now there are two goals in treatment. First thing, I should open the bronchus to facilitate oxygen entry. Second thing, I should also facilitate carbon dioxide exit. So to open this bronchus, I do high inspiratory flow. With this high inspiratory flow, your bronchus will be opened. And to facilitate carbon dioxide exit, I am going to prolong expiratory time, because these patients will be having low oxygen and increased carbon dioxide. I told you in life threatening asthma, oxygen will decrease, carbon dioxide can increase in the body. So this high inspiratory flow will facilitate oxygen entry. Prolonged expiratory time will be responsible for CO2 exit. Both are required in the management of life threatening form asthma. Then which of the following is not helpful in life threatening asthma? In life threatening asthma, you might require invasive mechanical ventilation, you might require prolonged expiratory time, you might need to give high inspiratory flow, but it is not inverse ratio ventilation. Now what is this inverse ratio ventilation? Normally when I connect a patient to ventilator, I have to set inspiration to expiration ratio. Usually I set it as 1:2. We all know expiration is slightly prolonged. To maintain that physiological value, I usually make inspiration as 1 second, expiration as 2 seconds. This is the general IE ratio. Whereas in asthma, I need to prolong expiratory time. IE ratio in asthma, what I am going to set is 1:3. Normally it is 1:2. In asthma, I set it as 1:3. Then what is this inverse ratio? Inverse means something opposite to normal ratio. What is normal ratio? 1:2. Inverse of 1/2 is 2/1. Inverse ratio 2:1. Inverse ratio ventilation means you are increasing the inspiratory time. This was initially used in ARDS. In the early 2000s, they thought that by increasing inspiration you can improve oxygenation. But later they have come to know that by aggressively doing inspiration there was lung damage, carbon dioxide was getting trapped in your body, and they ultimately found it was not beneficial. Now it is not used. Previously it was used in ARDS. Nowadays it is not used because of its adverse events such as lung damage and CO2 retention in the body. So point to remember, normal ratio is 1:2. Inverse means 2:1. In asthma we make it 1:3 to facilitate carbon dioxide exit, especially in the life threatening form. The answer will be option D. But fortunately, majority of patients will not be in exacerbation. They will be taking their routine medications, maintaining the asthma at home. Such asthma not in exacerbation is called as stable asthma. I am going to discuss stable asthma with respect to XENA 2021 update. Classification and stepwise therapy of stable asthma. Let us see the important drugs. There are two types of drugs. One is controller and other is reliever. Controllers are those which will decrease airway inflammation. Controllers are the drugs which will decrease airway inflammation, and preferred controllers in asthma are usually inhaled corticosteroids. Preferred controllers are usually inhaled corticosteroids. Along with inhaled corticosteroids, we can also give anti-leukotrienes, which will decrease the leukotriene action. Anti-leukotrienes such as montelukast, but preferred is always inhaled corticosteroids. Then we have reliever medication. These are emergency medications that can be used for relief of acute symptoms, also called as rescue medication. Previously, whenever a patient with asthma was having acute symptoms, they were only giving short acting beta 2 agonist. But the new guidelines have modified it to combination of low dose inhaled corticosteroid and formoterol. Now what is the reason for making such an important change? Now if you are only taking bronchodilator, now why is asthma happening? Because allergen mediated inflammatory response. You are only taking care of the effect, you are not taking care of the cause. See, that inflammation may proceed further also. If you just take a bronchodilator, it is only going to cause bronchodilation. It is not going to stop that inflammatory cascade. So to bring down that inflammation, you need some drug. That's why they started to give low dose inhaled corticosteroid. So low dose inhaled corticosteroid will take care of that inflammation, and it will reduce the worsening. It will reduce the worsening called as exacerbation. Then why we have chosen formoterol instead of short acting beta 2 agonist? See, the difference between formoterol and short acting beta 2 agonist is the onset of action of SABA, no doubt it is fastest action. So, fastest onset, but it is only for few hours, 4 to 6 hours only, whereas formoterol it is fast acting, but the duration is generally up to 12 hours. Now, mind it students, these patients are not in the hospital, they are at home. So, whenever you are prescribing something at home, you make sure you are giving treatment to the patient so that he no need to take frequent medication. So, if at all you give a drug which is not working long, patient will definitely miss the dose and there will be no proper bronchoprotection. Because this is the medication to be used in community, we go for fast acting. See, the difference is only 2 or 3 minutes. See, the onset of action of SABA is 2 to 4 minutes, whereas formoterol it will take 4 to 6 minutes, but the duration is more. Because of that, patient can comfortably use the medication at home. There will be better bronchoprotection. The reason for adding formoterol is prolonged bronchoprotection. The reason for adding low dose inhaled corticosteroid is to decrease exacerbation rates. But if they ask you in emergency department, what is the rescue medication of choice? Your answer should be still SABA, because in emergency situation, even that 1 or 2 minutes difference is very, very important. So, SABA acts quickly and it can be given to save the life of the patient in emergency situations in the emergency department. Whereas in routine community settings, if the patient is in home or patient at his workplace, if he develop asthma symptoms, as a rescue medication, according to new guidelines, what should be given? Low dose inhaled corticosteroid with formoterol. What is the benefit of this combination? It decreases exacerbation rates, better bronchoprotection. In the emergency department, what will be the rescue medication of choice? It is still SABA, because in emergency department, even that 1 or 2 minutes action of SABA, so SABA works early, even that 1 or 2 minutes can make a difference. So, in routine community settings, it is low dose inhaled corticosteroid formoterol. In emergency department, still it is SABA. Based on this, they have classified asthma treatment tracks for adults. So, previously there was only one track, now we are having 2 tracks. One is track 1, other is track 2. This track 1 is most preferred and recommended. Even in India, we will be following the track 1. Even in India, we will be following the track 1. Whereas track 2 is done only when track 1 is not possible because of some affordability issues or not preferred by patient. So, patient says that I am okay with my old medication, I don't want to change. Now, what is the difference between this track 1 and track 2? The difference is in this reliever medication. Track 1 follows the new guideline, that is reliever is low dose inhaled corticosteroid plus formoterol. Track 2 still follows the old guidelines, that is only plain SABA. Now, plain SABA inhaler, it is not that costly, it is only about 100 rupees. Whereas low dose inhaled corticosteroid formoterol, the inhaler is costly, 400 or 500. So, when is track 1 not possible? In low income group countries, African countries where affordability and supply is an issue, or are not preferred by the patient. See, the main difference between track 1 and track 2 is the reliever medication. In track 1, we follow the new guideline, that is low dose inhaled corticosteroid and formoterol. Whereas in track 2, it is the old guideline, that is SABA. For all practical purposes, in India also we will be following track 1, and in exam also mostly they will be asking track 1. So, write down stepwise management track 1. The only difference between track 1 and track 2 is that rescue medication. Now, the patient is classified into 2 groups, infrequent symptoms, frequent symptoms. So, patient is getting infrequent symptoms once in a while. frequent symptoms. Nearly daily he is getting symptoms. Again, in infrequent symptoms, it can be classified into two categories. Patients with symptoms less than 2 per month. Patient with symptoms less than 2 per month. Another category, patient is having symptoms more than 2 per month up to 4 to 5 days in a week. So, in a week he is getting 4 days symptoms. Now, frequent symptoms, nearly daily patient is having asthma symptoms on most days, and because of asthma he is having sleep disturbance more than or equal to 1 per week, Then next category in frequent symptoms is, now patient is getting daily symptoms morning, afternoon, evening, every day, and he is also having sleep disturbance because of asthma more than or equal to 1 per week. And most important, you have measured his lung function, his FEV1, it was low, it was persistently low, less than 60%. This is the next category. In infrequent symptoms, symptoms less than 2 per month, symptoms more than or equal to 2 per month to 4 to 5 days a week. Frequent symptoms, symptoms on most days, nighttime awakenings present. Whereas the next category, daily symptoms, nighttime awakenings present, along with that patient is having low lung function. Now, according to the category of the patient, we are going to adjust the medication. If the patient is having a less severe disease, we generally go for a less step, that is step 1. If the patient is having more symptoms, we are going to increase the step of treatment. According to the category, we have classified the treatment into step 1, step 2 for infrequent symptoms, step 3, step 4 for patient with frequent symptoms. Now, even after giving step 4 treatment, if patient is not improving, we go for step 5 treatment. So, the ultimate step is step 5. For infrequent symptoms, once in a while we go for step 1, step 2. For frequent symptoms, we either go for step 3 or step 4. Even if the patient is not improving with step 4 medication, the ultimate step that we have is step 5 medication, Now, let it be at any step, of treatment. If patient develops acute symptoms, immediately what he should do, he should take rescue medication. See, patient might be taking morning and evening his regular medication, but in afternoon he has developed some acute symptoms. Immediately you should advise him to take rescue medication. So, rescue medication is emergency medication. He should always keep in his pocket. Whenever he feels uncomfortable, he should take it immediately. Now, let us see what are the drugs that should be taken at the steps. Now, if the patient is belonging to infrequent symptoms, now what they have done is, to avoid confusion, in the new guidelines, they have merged both step 1 and step 2 together. So, to avoid confusion, they found out that in infrequent symptoms, irrespective of the symptoms, the treatment was the same. So, now in the new guidelines, it is written as step 1 to step 2, So, here the treatment will be the same. So, what will be the treatment? It will be combination of low dose inhaled corticosteroid and formoterol as needed. So, it means if the patient is having symptoms Monday, Wednesday, Saturday in a week, only on that day he can take low dose inhaled corticosteroid and formoterol. Rest of the days no need to take. So, according to new guidelines, they have merged step 1 and step 2 to avoid confusion. For all infrequent symptoms patients, on that day of symptom, if you take medication, it is sufficient. Later days no need to take. From step 3 onwards, I am dealing with frequent symptoms. So, this patient is having nearly daily symptoms. So, daily he should take treatment. In step 3, the treatment will be daily low dose inhaled corticosteroid with formoterol. From here onwards it will be daily. Now step 4, with step 3 patient did not improve, still he is having more symptoms. So what I do is I convert this low dose inhaled corticosteroid, to medium dose inhaled corticosteroid. So in step 4 I have increased the dose of inhaled corticosteroid from low to medium. Now still patient is not improving. Now this patient I am going to give step 5 management. So initially I can give high dose inhaled corticosteroid plus formoterol, very simple. From medium dose I am going to increase it to high dose. But at step 5 you should be very careful, because this patient is requiring high dose inhaled corticosteroid. If he is not improving, you should look for other options. You should refer to a specialist center where a pulmonologist will be present, and I am going to assess for biological therapy. In step 5 I should consider high dose inhaled corticosteroid and LABA. So I am going to increase the dose to high dose inhaled corticosteroid. I can also add LAMA. So LAMA is nothing but big brother of ipratropium, long acting muscarinic antagonist. We have tiotropium, long acting muscarinic antagonist. Available in market is tiotropium. Then I should refer the patient to a specialist center to consider for biological therapy. Refer the patient to specialist center to consider for biological therapy. So what is this biological therapy? We will discuss later. Now these are the drugs or medications that should be definitely given at that point of time. If the patient belongs to infrequent symptoms, this medication should be given. If patient belongs to frequent medications, these medications should be definitely prescribed to the patient. Apart from this, there are other options based on patient's affordability. You can also prescribe other drugs. From step 2 onwards, you can start anti-leukotrienes. What are anti-leukotrienes? Anti-leukotrienes are nothing but montelukast. And you can also give immunotherapy, giving low dose of allergen to increase the tolerance towards allergen. At step 5, you can add oral steroid. Previously in step 5, oral steroid was a regular treatment, but because of side effects of oral steroid, now it has been degraded to optional treatment. At step 5, oral steroid is not regular treatment, it is an optional treatment. And also recent evidence shows that you can also give azithromycin at step 5. Recent studies have shown that apart from antibacterial activity, azithromycin is also having anti-inflammatory property. That anti-inflammatory property can be used in asthmatics requiring step 5 treatment. At step 5, either oral steroid or you can add azithromycin. Then what is this biological therapy? Biological therapy is nothing but blocking antibodies. We have anti-IgE. Anti-IgE is nothing but omalizumab. Anti-IL-5. Anti-IL-5 we have mepolizumab, reslizumab. These are the drugs that are approved in India. There are also other biological therapies, but I am only discussing what are available and approved in our country. This is the stepwise management of asthma. Step 1, step 2 what to give, step 3 what to give, step 4 what to give, step 5 what to give. Now I will ask you a simple question. Now there was a 30-year-old female, beautiful. She came to your clinic, okay. Then you started her on asthma medications. You diagnosed her as asthma and you started her on step 3 medications, okay. You prescribed daily low dose inhaled corticosteroid with formoterol, and you also have given her your phone number. So if at all you have any problem, you call me. And you also told the patient you use this medication morning, evening, and in between you have any symptom, you should go for rescue medication. After 2 days, the patient returns back to your clinic, throws inhalers on your face, telling that my asthma is not getting controlled. What will you do next? What will you do next? So this patient, you put her effectively on step 3, but her symptoms are not coming down. What will you do next? Will you step up? The answer is no. Before stepping up treatment in asthma, there is one important thing that you should do. You should see the inhaler technique, because majority of the medications are given as inhalers. If the patient is not using inhaler properly, whatever medication you give will not reach her lung, it will not have any good benefit. That's why most important in asthma management is patient education. Patient should know how to use inhaler, active self management, when to use inhaler, adherence, regularly use inhaler, how to use inhaler, when to use inhaler, and regularly use inhaler. If you don't educate patient, things like this will happen. Actually, inhaler should be taken like this. Patients will start taking like this also and blame that your medication is not working. That's why most important in asthma is patient education, active self management, and adherence. Coming to the GINA definitions of asthma. So these are some retrospective definitions based on what treatment patient is requiring. If patient's asthma is requiring step 1 or step 2 treatment, it is called as mild asthma. Very simple definitions. If patient's asthma is requiring step 3 or step 4 treatment, it is called as moderate asthma. If patient is requiring step 5 treatment, that is high dose inhaled corticosteroid with LABA, it is severe asthma. Very simple classification. Patient is requiring only step 1, step 2 treatment. That phenomena is called as mild asthma. Patient is requiring step 3, step 4 medication. That is moderate asthma. If patient is requiring high dose inhaled corticosteroid LABA treatment, that is step 5 treatment, step 5 treatment. So that phenomena is called as severe asthma. These are all retrospective definitions from the GINA 2021 guidelines. This completes the routine management of asthma in community, and also we have discussed management of asthma in emergency department. Now who are these people? Beckham, Priyanka Chopra, Amitabh Bachchan. What is common in them? Their asthma. You can see Beckham taking an inhaler puff before attending penalty shootout. What is the asthma that I am going to discuss? Exercise induced asthma. So write down, in susceptible individuals. In susceptible individuals, exercise can induce asthma. Exercise can induce asthma. This is more during when somebody does exercise in cold and dry climates. This is more during when somebody does exercise in cold and dry climates. They will ask you, what is the drug of choice for short-term prophylaxis? What is the drug of choice for short-term prophylaxis? And what will be the drug of choice for long-term prophylaxis and overall control of the disease? And overall control of the disease. Now Beckham needs to attend a penalty shootout. He is worried he is going to develop bronchospasm, asthma. So what should be one drug that should be given before exercise? A short acting beta 2 agonist. If a short acting beta 2 agonist is given, so that is going to work for about 4 to 6 hours. Patient can complete the exercise and he can come back comfortably. Now if they ask you for long term prophylaxis and overall control of the disease, your answer should be inhaled corticosteroids. Inhaled corticosteroids. For short term prophylaxis, it is short acting beta 2 agonist. For long term prophylaxis and overall control, it will be inhaled corticosteroids. If SABA is not given in the option, you can go for anti-leukotrienes. And in few countries, they also prescribe mast cell stabilizers. They are prescribing mast cell stabilizers. But for all practical purposes, one drug, it is SABA for short term prophylaxis. For long term prophylaxis and overall control, it is ICS. Next we are going to discuss about a drug which will cause asthma, aspirin. In susceptible individuals, aspirin can block cyclooxygenase path and shifts balance towards lipooxygenase path resulting in increased leukotrienes that results in bronchospasm. What is happening here, students? In my body there is a substance called as arachidonic acid. This arachidonic acid, either through cyclooxygenase path or through lipooxygenase path, it is broken down. When it is broken down through cyclooxygenase path, the end products are prostaglandins, whereas here the end products are leukotrienes. Now this aspirin will block cyclooxygenase path and it will shift balance completely towards lipooxygenase path, because majority of arachidonic acid is getting converted into leukotrienes. The leukotrienes will significantly increase. Whenever leukotrienes increase, what is its function? Bronchospasm. Coming to the treatment, treatment will be combination of inhaled corticosteroids, beta 2 agonists, anti-leukotrienes. Whenever I discuss about aspirin induced asthma, I should tell you a combination. What is this combination? Nasal polyps, asthma and aspirin sensitivity. This combination is called as Samter's triad. It is called as Samter's triad. Previously, regarding aspirin induced asthma, only two questions were asked. What is responsible for aspirin induced asthma? What is the mediator? Your answer should be leukotrienes. And what are the components of Samter's triad? Your answer should be nasal polyps, asthma, aspirin sensitivity. Nasal polyps, asthma, aspirin sensitivity will be the contents of Samter's triad. Next, coming to an asthma called as brittle asthma. Only little is known about brittle asthma, but it is very important for your exam. It is a rare type, but it has a specific clinical scenario which will attract the examiners. Only little is known. Let us see that little about brittle asthma. This is an unpredictable asthma with exacerbations. We don't know what is going to happen next in this type of asthma. Based on the clinical presentation, there are two types. We have type 1 brittle asthma and other is type 2 brittle asthma. Before going into brittle asthma, let us see the normal lung function. Consider this is a graph between time and lung function. Let this be 0 lung function, 50% of lung function, 100% of lung function. In a normal individual, the lung function will not fluctuate much. It will be here. This is how normal lung function behaves. Now what happens in type 1 brittle asthma? There will be rapid and frequent fluctuations in lung function with exacerbations. One can notice frequent fluctuations. The exact mechanism is not known. It is all based on observations. Frequent fluctuation in lung function with exacerbation, because always the patient that is at risk of exacerbation, he requires high dose inhaled corticosteroids, continuous beta 2 agonist, oral steroids. This is regarding type 1. Frequent rapid fluctuations in lung function with exacerbation. Coming to type 2 brittle asthma. Initially there will be near normal lung function, but one day there can be sudden decline in lung function that can result in death of the patient. Sudden decline in lung function that can result in death of the patient. Initially near normal lung function, followed by sudden decline, that can also result in death of the patient. Now what was the reason for such a sudden decline? They found out that allergen must have triggered a severe airway anaphylaxis. Now if it is asthma, it is only bronchospasm. My body can easily fight with bronchospasm. If it is severe airway anaphylaxis, it is laryngospasm. My body cannot fight with laryngospasm. It can give up, resulting in death. So what will be the treatment? If you find any patient in this condition for anaphylaxis, treatment is always adrenaline. These are the two types of brittle asthma, type 1, type 2. These are generally rare in clinical practice, but they have a specific clinical scenario which can attract the examiner to give a question. Let us see a clinical scenario based case. 32-year-old female with a history of intermittent wheezing in response to exercise presents to the emergency room with shortness of breath. Her attack occurred during an aerobics class. She was doing aerobics, then she got the attack. At this point, she is having difficulty in breathing and has diffuse wheezes on pulmonary examination. The most effective treatment. She is having asthma which made her to come to emergency room. Bilateral diffuse wheezes, difficulty breathing. All these are suggestive of acute severe asthma exacerbation. Of acute severe asthma exacerbation. So in acute severe asthma exacerbation, what should be done immediately in the emergency department? You should go for bronchodilation. What should be given? Inhaled albuterol. The best answer is inhaled albuterol. This is regarding asthma. We have discussed the Xena 2021 update, various types of asthma and what are the treatment options in emergency department and also for regular treatment of asthma in community.